Hello students, and here in this class we are going to discuss about the anatomy of the ulnar nerve. So the ulnar nerve is often referred as the nerve of the hand, or we can also call it as the musician's nerve, because it innervates the vast majority of the intrinsic muscles of the hand. So if we talk about the origin of the nerve, the ulnar nerve originates as the terminal branch of the medial cord of the brachial plexus. We can see the brachial plexus and we can see all the three cords, that is lateral, posterior and medial here. And we can see the medial cord. So the terminal part of the medial cord of the brachial plexus gives off one of the major nerve called as ulnar nerve. And it derived from the anterior ramus of C8 and T1 spinal nerves with a variable contribution from C7. Let us talk about the course of the nerve as well as its distribution. So we have to discuss the course as well as distribution according to the various segments of the upper limb, that is in the arm, forearm as well as in the hand. First, let us discuss about the course and distribution of the ulnar nerve in the arm. So, in the arm, the ulnar nerve runs medial to the axillary artery. Right? We can see here very clearly, it runs medial to the axillary artery. And subsequently, the brachial artery on the coracobrachialis muscle in the anterior compartment of the arm. And it descends down along the medial aspect of the arm, that is medial to the biceps brachii and medial to the brachialis muscle. So here in the middle of the arm, see carefully here, in the middle of the arm, the ulnar nerve pierces the medial intermuscular septum and heads posteriorly where it lies close proximity to the humerus and to the medial head of the triceps brachii muscle and the tendon, that is in the lower part of the arm. For example, if you see in 70 to 80% of the individuals, the ulnar nerve passes under the arcade of Struthers. So what is the arcade of Struthers here? So this arcade of Struthers is a thin aponeurotic band that extends from medial head of the triceps to the medial intermuscular septum, and it is located approximately 8 centimeters above the elbow. This is the exact location where we can find the arcade of Struthers. And the nerve runs along the lower aspect of the posterior compartment of the arm, which means once the nerve enters the posterior compartment, which runs along the lower aspect of the posterior compartment of the arm, along with the superior ulnar collateral artery, which means in the lower aspect of the posterior compartment of the arm, the ulnar nerve runs along with the superior ulnar collateral artery. So further on, it runs between the medial head of the triceps brachii muscle and pass posterior to the medial epicondyle of the humerus in the superficial condylar groove, which is often referred as cubital tunnel, which means from the posterior aspect of the medial epicondyle of the humerus, the nerve enters into the cubital tunnel. So what is the cubital tunnel here? The cubital tunnel is a space through which the ulnar nerve passes posterior to the medial epicondyle of the humerus. This is what we need to know about course of the ulnar nerve in the arm. Did we discuss about the distribution of the ulnar nerve in the arm? No, we did not, because it has no motor or sensory branches in the arm. Remember, ulnar nerve does not give any of the motor or the sensory branches in the arm. Now let us discuss about the course and distribution of the ulnar nerve in the forearm. So we know that it enters into the cubital tunnel. From there, it should enter the forearm, right? So it enters the forearm by passing the cubital tunnel through the two heads of flexor carpi ulnaris muscle, right? So it has to pass between the two heads of the flexor carpi ulnaris muscle. Before that, it should pass through the cubital tunnel. So this cubital tunnel, if you see very carefully here, the roof of the tunnel is the humero-ulnar arcade proximally, and the substance of the two heads of the flexor carpi ulnaris muscle distally. This is how the roof of the tunnel has been formed. And when we talk about the floor of the tunnel is composed of the medial elbow ligaments proximally and the deep fibers of the flexor carpi ulnaris muscle more distally. So this is how the roof and floor is formed, and the tunnel is formed so that it can accommodate the ulnar nerve. Now the nerve descends down the forearm, that is superficial to the flexor digitorum profundus muscle, which means it runs over the flexor digitorum profundus. And if you see the forearm very carefully here, in the upper part of the forearm, the ulnar nerve is covered by the flexor carpi ulnaris. But if you carefully examine at the lower part of the forearm, it is only covered by fascia and the skin and lies lateral to the flexor carpi ulnaris, and the ulnar artery lies lateral to the top of the nerve. This is how we can relate the structures which are present in the forearm. And in the forearm, it gives off a branch called as articular branch to the elbow joint. Now let us talk about muscular branches. So it gives off two muscular branches, that is in the forearm. One branch to the flexor carpi ulnaris and second muscular branch to the medial half of the flexor digitorum profundus. Let us see the flexor digitorum profundus muscle here. It has medial half and a lateral half. So the medial half of the flexor digitorum profundus is innervated by the ulnar nerve because the lateral half of the muscle is supplied by the median nerve. So other than the flexor carpi ulnaris and flexor digitorum profundus, all the muscles in the anterior compartment of the forearm is supplied by the median nerve. Remember this point very carefully. All the muscles of the anterior compartment is innervated by the median nerve except the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. These two are supplied by the ulnar nerve in the forearm. Now let us talk about the course and distribution of the ulnar nerve in the hand. So from the forearm, the nerve should enter into the hand. So the ulnar nerve enters the hand, that is superficial to the flexor retinaculum and inside the Guyon's canal. So what I am trying to say here is the Guyon's canal is located or situated superior or superficial to the flexor retinaculum. Right? Now, we can also see a branch which is coming off. What is the branch name? Dorsal cutaneous branch. So the dorsal cutaneous branch given off in the hand before the nerve enters the Guyon's canal, right? Can we see the branch very clearly? Before the ulnar nerve enters into the Guyon's canal, we can see the branch here, which supplies the sensation to the back of the ulnar 1.5 digits. Now we are at the level of the Guyon's canal. So it is important for us to understand the formation of the Guyon's canal here. So this Guyon's canal is bordered medially by the pisiform and the pisohamate ligament. Right? We can see the structures very clearly here. and laterally it is bounded by the hook of the hamate. And the hypothenar muscles and the flexor retinaculum forms the floor. The flexor retinaculum is also called as transverse carpal ligament, which forms the floor. And the superficial structures are the palmar carpal ligament and the palmaris brevis muscles, which forms the roof. So this is how the Guyon's canal is formed. So after the nerve enters into the hand, that is immediately after the Guyon's canal, once the nerve enters into the hand, it divides into superficial as well as deep branches at the level of the pisiform bone. So at the level of the pisiform bone, the nerve divides into superficial and deep branches. So let us discuss separately about the deep branches and the superficial branches. So the deep branch, we can see here, first pierces and innervates the opponent's digiti muscle and then given off a branch to the remaining hypothenar muscles just after emerging from the Guyon's canal. So the deep terminal branch innervates here vast majority of intrinsic muscles of the hand. That is the reason we called the ulnar nerve is called as the musician's nerve or the nerve of the hand, because it innervates majority of the intrinsic muscles of the hand. These include all the interossei, that is 4 dorsal and 3 palmar interossei, and medial 2 lumbricals are innervated by the deep branch of the ulnar nerve. And it finally terminates in the thenar eminence, where it supplies the adductor pollicis and also variable portions of the flexor pollicis brevis muscles. This is how the deep branch is getting terminated. So that is the reason when we are considering the ulnar and median nerve, they should be considered as a pair, because the median nerve is giving off majority of its innervation in the forearm and the ulnar nerve is doing majority of the innervation in the hand. So this is how the ulnar nerve as well as median nerve distributed their territories according to its supply. So after discussing about the deep branch, now let us talk about the superficial branches of the ulnar nerve. So in the hand, that is after giving off a branch to the palmaris brevis muscle, the superficial terminal branch supplies the cutaneous ulnar border of the palm and then divides into 2 digital branches, and those 2 digital branches innervates the palmar or the volar surfaces of the 5th and ulnar half of the 4th digit. This is how the sensory innervation can be defined. And we can also see one of the branch called as palmar cutaneous branch, separate branch of the ulnar nerve, right? So the palmar cutaneous branch arises in the mid of the forearm. It is nowhere associated with the hand, because we are discussing about the superficial branches. There's a reason we are discussing this nerve over here. So the palmar cutaneous branch arises in the mid forearm and runs distally over the volar aspect of the forearm and the wrist without passing through the Guyon's canal. And it supplies the cutaneous territory over the proximal border of the ulnar portion of the palm, which also supplies the palmar aponeurosis. This is the distribution of the palmar cutaneous branch of the ulnar nerve. Now let us talk about the dorsal cutaneous branch. We have discussed this earlier, but let us discuss in a more precise way. So the dorsal cutaneous branch is given off more distally, right? That is approximately 5 centimeters proximal to the top of the wrist, and courses dorsally around the ulna to supply the ulnar side of the dorsum of the hand and dorsal surfaces of the 5th and ulnar half of the 4th digit. This is what we have discussed earlier. So by this we completed the deep as well as the superficial branches of the ulnar nerve. Now let us focus on the clinical anatomy. Generally, injury to the ulnar nerve may be seen at the level of the arm or the forearm or the hand, right? Or maybe at the elbow. But the most often the injuries of the elbow are more commonly seen when compared to that of the hand or any other location. So all these injuries are referred in a common pool called as ulnar neuropathies. So in general, ulnar neuropathy, that is especially at the elbow, is a common focal neuropathy affecting the upper extremity, and it is second in frequency only after the entrapment of the median nerve at the wrist, that is the carpal tunnel syndrome. So the most common peripheral nerve neuropathy of the upper limb is the carpal tunnel syndrome, and second most common is the ulnar neuropathy. In that also most common will be the cubital tunnel syndrome. So that is the reason, the point to be noted here, that the most common site of the focal ulnar entrapment or the compression is at the elbow, followed by the wrist. This is what we have to remember here. And now one of the interesting point we have to discuss, known as the ulnar paradox. So it is a terminology here. What is the meaning of a paradox? Which means it is behaving differently compared to that of the other nerve injuries of the upper limb. What exactly I mean by this? Generally, we often discuss that more proximal a nerve injury, the worse will be the signs and symptoms and also the prognosis. When we talk about the median nerve or the radial nerve, the proximal injuries are more symptomatic compared to that of the distal injuries. But the opposite is true when we consider the ulnar nerve. This is because one of the muscles that flexes the fingers, that is flexor digitorum profundus, which lies in the forearm, is partially innervated by it, right? Because half is innervated, that is medial half is innervated by the ulnar and the lateral half is innervated by the median. So that is the reason proximal injury will remove innervation to the forearm muscles and the hand muscles. But when we talk about the distal injury, so a distal injury only takes out the hand muscles, hence the still functioning finger flexors give the patient a clawed appearance in the ring as well as a little finger. So with a proximal injury leading to an open palm, there is more capacity for the hand function when compared to that of the distal injuries. So this phenomena overall is called as ulnar paradox. Now we have two important clinical scenarios here when we talk about ulnar neuropathies. One is the cubital tunnel syndrome and second one is called as Guyon's Canal syndrome or Guyon's tunnel syndrome. So what is the cubital tunnel syndrome? We know about the cubital tunnel, right? So entrapment of the ulnar nerve occurs when the nerve is compressed, typically at the elbow or maybe at the wrist. As I already mentioned earlier, that the compression of the nerve at the elbow is pretty common when compared to that of the wrist. And compression of the nerve at the elbow is called as tardy ulnar palsy. Nowadays we are calling the same tardy ulnar palsy as the cubital tunnel syndrome, which is the most common ulnar nerve neuropathy. So what might be the causes of cubital tunnel syndrome here? It may be because of leaning on the elbow, or maybe due to the prolonged elbow flexion during various type of occupational activities like leaning on the desk on the elbow, or maybe because of athletic activities, or maybe because of the surgical procedures, that is during general anesthesia. There may be injury to the nerve at the cubital tunnel, or sometimes it may be because of the blunt trauma of the nerve, or maybe because of the masses which is compressing the nerve, examples like tumors or hematomas, or maybe in metabolic abnormalities like in diabetes, because majority of the peripheral nerves are affected. But more commonly it is a compressive neuropathy and most often because of the occupation. And the cubital tunnel syndrome can cause a pain on the medial side of the lower forearm with pins and needle sensation of the medial two fingers and dorsum of the ulnar side. This is what we need to know about the cubital tunnel syndrome. And what is the Guyon's canal syndrome? So compression of the ulnar nerve at the wrist is referred as Guyon's canal syndrome, and we can also call it as ulnar tunnel syndrome. So the causes most often will be idiopathic or may be associated with cycling, probably caused by the direct pressure from the handlebars, or maybe the masses with the ganglionic thrust being the most common cause which is responsible for compression of the nerve in the Guyon's canal, or maybe because of the blunt trauma in conditions like fracture of the hook of the hamate. So any of these causes can cause ulnar nerve entrapment or the injury at the Guyon's canal. Now let us talk about the overall clinical features. So when we talk about the clinical features, the first important thing what we need to discuss is about the muscle weakness and atrophy. Remember very carefully here, lesions at the elbow usually involves muscles of the hand and the forearm. But the lesions at the wrist only involve muscles of the hand because of the location of the injury here. So when we talk about the muscles of the hand specifically, first dorsal interosseous muscle and the abductor digiti minimi, these are the muscles which are more commonly affected. So when we talk about the muscles of the forearm, the more commonly the muscles which are affected will be the flexor digitorum profundus and the flexor carpi ulnaris, right? These are the two muscles which are innervated by the ulnar nerve in the forearm. Now we have to discuss about a phenomena called as claw hand deformity. When we see the little and ring fingers here, so there will be a loss of extension at the little and ring fingers at the proximal interphalangeal joint and loss of flexion at the metacarpal phalangeal joint. This is why we will see the ulnar claw hand. So ulnar claw hand will be usually worse when the lesion occurs at the wrist as opposed to that of the elbow because of a greater muscle imbalance. So the wrist lesions usually present with the weakness of the third and fourth lumbrical muscles, while the flexor digitorum profundus of the fourth and fifth digits are spared, unlike the lesions at the elbow in which both are affected. Now let us talk about the Wartenberg sign. So in the Wartenberg sign, the little finger will be in the persistent abduction. So persistent abduction of the little finger is called as Wartenberg sign. It is mainly due to weak third palmar interosseous muscle. Next, another important sign what we need to know about the ulnar nerve palsy will be Froment sign. This Froment sign, not to be confused with the Froment maneuver what we have in the Parkinson's disease here. Sign is different, maneuver is different. So what is the Froment sign? So here the thumb flexes at the interphalangeal joint while pinching a piece of a paper to compensate for a weak adductor pollicis muscle called as Froment sign. Now let us discuss about the sensory loss. So there will be loss of sensation over the hypothenar eminence and ulnar one end of fingers because of its distribution. So if there is a lesion at the elbow, there will be a positive renal test too. That is also very important for us for the examination point of view as well as to identify the ulnar neuropathy. So whenever we talk about the renal test, the renal test will be positive. So there will be a marked paresthesias which can be reproduced in the ulnar portion of the hand by tapping on the medial epicondyle of the humerus. This is called as the renal test, which is positive whenever there is injury of the nerve at the elbow. Now when we talk about the lesions at the wrist, Especially whenever we talk about the lesions at the wrist, sensory symptoms may or may not be present, but it is not in the case of the lesions at the elbow. Now let us talk about the pain in ulnar neuropathy. So elbow lesions typically present with a referred pain in the forearm, where the pain rarely occurs with the wrist lesions. So remember the point that the pain is more commonly seen in the cubital tunnel syndrome, but not in the Guyon's tunnel syndrome. So overall, what we need to know here is whether it is a proximal or a distal lesion, both can lead to a claw hand deformity. So what we need to remember by this is, whatever may be the level of the injury, we can see ulnar claw hand here. The degree of the clawing may be different, but we can see the ulnar claw hand if there is a lesion at the elbow or at the wrist. Now let us talk about the diagnosis of ulnar neuropathy. So electromyography. So in majority of the nerve injuries, we often perform EMG, called as electromyography. It is the main confirmatory diagnostic test because it specifically identifies the level of the nerve compression or the level of the lesion. So other than EMG, we often perform ultrasound and MRI. Mainly, we perform this ultrasound and MRI because to support the EMG findings and also to detect the possible causes of compression. Example, maybe in the case of space occupying lesions. So this is about the diagnosis. Now let us talk about the treatment. So treatment can be divided under two headings, conservative therapy as well as the surgical therapy. Conservative therapy can be given in very milder cases. For example, if there is a pain, analgesics can be given in the form of non-steroidal anti-inflammatory drugs. And majority of the cases, these neuropathies are because of the occupational types. There's a reason modifying the behavior, that is avoiding prolonged resting on the elbow or repeated flexion of the elbow, that can be prevented. That is how you guide the patient to change his behavior or modify the pattern of his occupation, and do not use the elbow too much, approximately for 4 to 6 weeks. And also in some of the conditions we do bracing. So bracing at night. So the surgical decompression can be done. That is, if clinical features are severe or persistent, that is, if the clinical features are lasting more than 6 to 12 weeks, then we go for surgical decompression, or progressively worsen despite of the conservative therapy, then also we go for surgical decompression. So this is about the treatment of ulnar neuropathy. So by this we completed the detailed anatomy of the ulnar nerve along with its clinical applications.